Clinical description and prevalence of ADHD. What distinguishes the hyperactive behavior from a diagnosable disorder? When these behaviors are extreme for a particular developmental period, persistent across different situations, and are linked to significant impairment in functioning, the diagnosis ADHD may be appropriate. ADHD children have great deal of difficulty sustaining their attention on a task of activity. Their tasks are often unfinished and they often seem not being able to listen when someone else is speaking. In addition to this serious disruption in attention, some children with ADHD display motor hyperactivity. They are unable to sit at one place in a school for more than a minute. Their restlessness in the school is a considerable source of concern for the teachers and peers. In addition to hyperactivity and problems sustaining attention, impulsivity, acting apparently without thinking, is a common complaint made about them. DSM-4-TR differentiate three types of symptoms. The first include problem of inattention. They appear not to listen to others. They may lose necessary school assignments, books, and they may not pay enough attention to details. They make careless mistakes. The second type of symptoms include hyperactivity, which includes fidgeting, having trouble sitting for any length of time, always being on the go. The third general symptom is impulsivity, which includes blurting out answers before questions have been completed and having trouble waiting turns. Either the first or second and third domains of symptoms must be present for someone to be diagnosed with ADHD. Inattention, hyperactivity, and impulsivity often cause other problems that appear secondary to ADHD. Academic performance tends to suffer, especially the child progresses in school. The cause of this performance is not known. It could be a result of the problem with attention and impulsivity characteristics of ADHD, and in some children this can be made worse by factors such as concurrent learning disability, which are common in boys with ADHD. Children with ADHD are likely to be unpopular and rejected by peers. Evidence suggests that some children with ADHD actually have an inflated sense of their own competence in areas such as social acceptance, physical appearance, and self-worth. Internalizing disorders such as anxiety and depression also frequently co-occur with ADHD. Recent estimates suggest that as many as 30% of children with ADHD may have comorbid internalizing disorders. In addition, about 15 to 30% of children with ADHD have a learning disability in math, reading, or spelling. And many children with ADHD are placed in special educational programs because of their difficulty to adjusting to a typical classroom environment. Although having both ADHD and conduct disorder is associated with substance use and abuse, a prospective study found that the hyperactive symptoms of ADHD predicted subsequent substance use at the age 14 and abuse or dependence at the age 18, even after controlling for symptoms conduct disorder, and this was equally true for boys and girls. The consensus on prevalence estimates of ADHD is that 3 to 7% of school children worldwide currently have ADHD are used across countries as diverse as US, Kenya, and China. However, one study reported a much higher prevalence rate of 16.1% of ADHD. The disorder occurs most frequently among pre-adolescent boys. It is 6 to 9 times more prevalent among boys than among girls. ADHD occurs with the greatest frequency before age 8 and tends to become less frequent and to involve briefer episodes thereafter. ADHD has also been found to be comorbid with other disorders such as oppositional defiant disorder. Some residual effects such as attention difficulties may persist into adolescence or adulthood. In India, the prevalence of ADHD among primary school children was found to be 11.32%. Prevalence was found to be higher among the males, which is 66.7%, as compared to that of females, which is 33.3%. The prevalence among lower socioeconomic group was found to be 16.33%, and that among middle socioeconomic group was 6.84%. The prevalence was highest in the age group of 9 to 10 years. Now we have DSM-4TR criteria for attention deficit hyperactivity disorder. This criteria suggests that either of the following criteria would enable a diagnosis of ADHD. Number 1. If 6 or more of such following symptoms of inattention have persisted for at least 6 months and are maladaptive for the child's developmental level. Inattention, that is A, often fails to give close attention to details or makes careless mistakes in the schoolwork, work or other activities. B, often has difficulty attending in tasks or play activities. C, often does not seem to listen when spoken directly. D, often does not follow through on instructions and fails to finish schoolwork, chores and duties in the workplace. E, often has difficulty organizing tasks and activities. F, often avoids, dislikes or is reluctant to engage in tasks that require sustained mental effort such as schoolwork or homework. G, is often easily distracted by the extraneous stimuli. H, is often forgetful in daily activities. Number 2. If 6 or more of such following symptoms of hyperactivity impulsivity have persisted for at least 6 months to a degree that is maladaptive. A, often fidgets with hands or feet or squirms in seat. B, often leaves seat in classroom or in other situations in which remaining seated is expected. C, often runs about or climbs excessively in situations in which it's inappropriate. For example, in adolescent or adults may be limited to subjective feelings of restlessness. D, often has difficulty playing or engaging in leisure activities quietly. E, is often on the go or often acts as if driven by a motor. F, often talks excessively. Impulsivity. G, often blurts out answers before questions have been completed. H, often has difficulty awaiting turn. I, often interrupts or intrudes on others, for example, butts into the conversation or the games. Causal factors in attention deficit hyperactivity disorder. It still remains unclear to what extent the disorder results from environmental or biological factors, and recent research points to both genetic and environmental precursors. Many researchers believe that biological factors such as genetic inheritance will turn out to be important precursors to the development of ADHD. But firm conclusions regarding any biological basis for ADHD still awaits further research. Genetic factors. Substantial evidences indicate that a genetical predisposition towards ADHD plays a role, and numerous large-scale studies have indicated a genetic component to ADHD, with heritability estimates as high as 70 to 80%. Most attention to date focuses on genes associated with the neurochemical dopamine, although norepinephrine, serotonin and gamma-aminobutyric acid are also implicated in the cause of ADHD. There is a strong evidence that ADHD is associated with the D4 receptor gene, the dopamine transporter gene DAT1, and the dopamine D5 receptor gene, that is DAT1, is of a particular interest because Ritalin is one of the most common treatment for ADHD that inhibit this gene and increase the amount of dopamine available. Even with these promising findings, most investigators disagree that a single gene will not ultimately account for ADHD. Rather, several genes interacting with environmental factors will provide the most complex picture of the cause if ADHD. Additional gene-environment interaction studies are underway, and if these findings replicated, we have a clear picture of how genes and environment interact in ADHD. Next, we have neurobiological factors. Studies have suggested that the brain structure and function differ in children with and without ADHD, particularly in areas of the brain linked to the neurotransmitter dopamine. For example, studies of brain structure have found that the dopaminergic area of the brain, such as caudate nucleus, frontal lobes, are smaller in children with ADHD than those without ADHD. Studies of brain functions have found that children with ADHD exhibit less activation in frontal areas of the brain while performing different tasks as compared to those children without ADHD. Moreover, children with ADHD perform poorly on neuropsychological tests that rely on the frontal lobe, providing further support for the theory that a basic deficit in this part of the brain may be related to this disorder. Prenatal and perinatal factors. Other neurobiological risk factors for ADHD include a number of perinatal and prenatal complications. Low birth weight, for example, is a quite specific predictor of the development of ADHD. Other complications associated with childbirth as well as mothers' use of substance, for example tobacco and alcohol, are also predictive of ADHD symptoms. Environmental toxins. Early theory of ADHD that were quite popular in 1970s involved the role of environmental toxins in the development of hyperactivity. Feingold proposed that additives and artificial colors in the foods upset the central nervous system of the children who are hyperactive, and he prescribed a diet free of them. However, well-controlled studies of so-called Feingold diet have found very few children with ADHD respond positively to it. Even though these early findings did not support Feingold theory, researchers still continue to examine how different elements of the diet, particularly additives, may influence hyperactive behavior. A recent study found a similar small effect of food additives and artificial coloring on hyperactive behavior. The popular view that refined sugar can cause ADHD has not been supported by careful research, although some evidence suggests that lead poisoning may be associated to a small degree with symptoms of hyperactivity and attentional problems. Researchers still continue to test whether lead exposure might play a role, however, a small, in the etiology of ADHD. Nicotine, specifically maternal smoking, is an environmental toxin that plays an important role, however small, in the etiology of ADHD. Several animal studies indicate that a chronic exposure to nicotine is associated with decrease in dopamine release in the brain and causes hyperactivity. Researchers hypothesize that maternal smoking can affect the dopaminergic system of the developing fetus, resulting in behavioral disinhibition and ADHD. Psychological factors in ADHD. Research results support that neurological and genetical factors more than psychological factors in the etiology of ADHD, which are parent-child relationship, interact with these neurobiological factors in a complex way to contribute to ADHD. Just as parents of the children with ADHD may give them more commands and have negative interactions with them, so these children have found to have more negative interactions with their parents. Certainly, it must be difficult for the parents to deal with a child who is impulsive, aggressive, non-compliant, and unable to follow the instructions. It was seen that stimulant medication has been shown to reduce hyperactivity and increase compliance in some children with ADHD. Significantly, when such medication is used either alone or in combination with behavioral treatment, it is also very important to note parents' own history. There appears to be substantial genetic component to ADHD, thus it is not surprising that many parents of the children with ADHD have had ADHD themselves. Treatment of ADHD. Although hyperactivity syndrome was described to be 100 years old, the disagreement over the most effective method of treatment still continues, especially regarding the most effective method of treatment like use of drugs to calm down the hyperactive child. Stimulant medications. The first class of medication used for children with ADHD is the stimulants. Stimulant medications such as methylphenidate or Ritalin have been prescribed for ADHD since the early 1960s. Other medicines approved by FDA to treat ADHD include Adderall, Concerta, Strattera. In 2006, an estimated 2.5 million children in the United States were taking stimulant medication, according to the National Survey on Children's Health in 2003, including almost 10% of all 10 years boys. These drugs have proved helpful for more than 70% of the cases in at least temporarily reducing hyperactivity and impulsivity and improving concentration on tasks. Adderall, which is a longer acting version of these psychostimulants, reduces the need for multiple doses for children during the day but has similar positive effects. Originally, it seemed contrary to expect that children would calm down after taking stimulant. However, on the same low doses, children and adults with or without ADHD react in the same way. It appears that stimulant medication reinforce the brain ability to focus attention during problem-solving tasks. Although the use of stimulant medication remain controversial, especially for children, most clinicians recommend them temporarily in combination with psychosocial interventions to help improve children's social and academic skills. Research suggests that other drugs such as one of the antidepressants, which are bupropion, imipramine, and a drug used for treating a high blood pressure, that is clonidine, may have similar effects on people with ADHD. Not all children with ADHD have depression or high blood pressure, though depression can be a problem in the portion of these children, but these drugs work on the same neurotransmitter system, which is norepinephrine and dopamine, which are also involved in ADHD. All these drugs seem to improve compliance and decrease negative behaviors in many children, and the effects do not usually last when the drugs are discontinued. Psychological treatment. Some portion of the children with ADHD do not respond to medication, and most children who do respond show improvement in ability to focus their attention but do not show gains in the important areas of academic and social skills. In addition, the medication often results in unpleasant side effects such as insomnia, drowsiness, or irritability. Because of these findings, researchers have applied various behavioral interventions to help these children at school and in home. Reinforcement programs reward the child for improvements and at times punish misbehavior with loss of rewards. Other programs incorporate parents' training to teach families as to how to respond constructively to their children's behavior and how to structure the child's day to help prevent difficulties. Social skills training for these children, which includes teaching them how to interact appropriately with their peers, also seems to be an important treatment component. For adults with ADHD, cognitive behavioral interventions for the distractibility and organizational skills problems appear quite helpful. Most clinicians typically recommend a combination of approaches designed to individualize treatments for those with ADHD, targeting both short-term management issues and long-term concerns, which are preventing and reversing academic decline and improving social skills. School intervention for children with ADHD, that includes training teachers to understand the unique needs of these children and to apply operant techniques in the classroom. Providing peer tutoring in academic skills and having teachers provide daily reports to parents about in-school behavior, which are followed up with rewards at home. Research has demonstrated that certain classroom structures can help children with ADHD. Ideally, teachers vary the presentation format and materials used for tasks, keep assignments brief, and provide immediate feedback on whether they have been done correctly. Have an enthusiastic and task-focused style, provides break for the physical exercise, use computer-assisted drill programs, and schedule academic work during the morning hours. Such environmental changes are designed to accommodate the limitations imposed by this disorder rather than to change the disorder itself. Some controversies surround the interpretation of these findings, specifically whether or not the combination of behavioral and medical treatments is superior to medication alone. One of the concerns surrounding the study was that although medication continued to be dispensed, the behavioral treatment was faded over time, which may account for the observed differences. Practically, If there is no difference between these two treatments, most parents and therapists would opt for simply providing medication for these children. Behavioral interventions have the added benefit of improving aspects of the child and family that are not directly affected by the medication. Despite these advances, however, children with ADHD continue to pose a considerable challenge to their families and to their educational system. Summary: ADHD is one of the most common behavioral problems of childhood. In this disorder, the child shows impulsive, overactive behavior that interferes with his ability to accomplish tasks. This disorder is common in boys than girls. Genetic factors play a particularly important role in ADHD. Neurobiological research has implicated the area of the brain and neurotransmitters such as dopamine in ADHD. Family and peer variables are also important factors to consider, especially in how they interact with genetical vulnerabilities. The most effective treatment of ADHD is a combination of medications such as Ritalin and behavioral therapy. Behavioral therapy, cognitive behavioral methods had shown a great deal of promise in modifying the behavior of hyperactive. More longitudinal research is clearly needed before we can conclude that children with ADHD go on to develop similar or other problems in adulthood. Estimates of the number of children with ADHD in adulthood are likely to vary considerably.